Okay, hi everyone. Thank you for joining us this evening. Today's tutorial is on abdominal pain given by Nur. Just a few rules before we start. For those of you watching via Zoom, any questions or comments, you could just add them into the chat or the Q&A. If you're watching on the Facebook Live, just comment your questions and we'll make sure that we pass them on. That's all from me, and I'll hand over to Nur to begin. Thank you.
Hi guys, good evening. My name's Nur. I'm a Foundation Year 2 doctor currently working in North Devon. So I'm very, very junior, and this topic will be sort of catered towards the early years of working. So it's not going to be like a very surgical specialized kind of thing. So very basics, and all of the materials that I've gotten for this presentation is from the Royal College of Surgeons of England e-learning for healthcare on abdominal pain. So this is a disclaimer page from becoming a doctor. Right, so hopefully by the end of this whistle-stop session, you'll be able to take a concise pain history. I'm sure most of you are able to do that. Classify abdominal pain according to location, differentiate abdominal pain according to examination findings, and investigate abdominal pain using appropriate modalities. So the aim of this, doing all of this, is to diagnose and later treat for abdominal pain. Right. So, quick introduction. Basically, abdominal pain is the most common presenting symptom on a general surgical on-call. Basically, I think about 90% of patients presenting to the local surgical assessment unit comes in with abdominal pain. So it's really, really important that we do a thorough history and examination so that we can formulate differential diagnosis and treat the patients. And this figure comes from the Royal College. 80% of the time, an experienced medic can correctly diagnose the cause of abdo pain by history taking alone. So this shows how important history taking is. And from the history taking, and then basically the other 20% would be the examination. And then we can formulate a diagnosis and then treat the patient. Right, taking a pain history. Can people tell me how we normally take a pain history? If you can put it on the chat or... See, Socrates, very good. And can you tell me what Socrates stands for? Something that we learn in med school first year. Really, really good. So site, onset, character, radiation, associated symptoms, timing, exacerbating and relieving factors, and severity. I think everyone knows every letter. Just go through them really quickly. So site we'll cover in a little bit. The 4 quadrants of the abdomen, or the 9 regions of the abdomen. Onset, was it gradual? Was it sudden? Character is quite difficult, but one character of pain that's quite specific is if you've heard renal colic, loin to groin pain, quite colicky, spasmy sort of pain. That's usually quite specific. Most abdominal pain aren't very specific. Radiation, where do they go? This is especially important in renal colic, loin to groin, so flank to the groin. In appendicitis, where they start centrally and then they migrate. And then associated symptoms, do they have a fever with it? That could point more towards an infection. Have they been vomiting? Do they have diarrhea? timing is quite similar to onset, but then it's more like duration. How long have they been having the pain for? Is it a day? Is it a week? Exacerbating and relieving factors, and also severity. Severity is quite difficult because different people have different pain thresholds, and it's quite subjective, so it's usually quite difficult and normally doesn't tell us very much. Right, so the abdomen, we do it two ways mainly, which is the 4 quadrants: left upper, right upper, lower. But the 9 regions would be more specific. Can we name the 9 regions? I think they have a few different names for some of the regions. Yep, so we have epigastric, right at the top, middle. Right. Anybody else? Okay, so we have the right hypochondriac region, epigastric, and then left hypochondriac. We have the right lumbar, or sometimes people call it right flank, right loin, umbilical region or periumbilical, left lumbar flank loin, right iliac region, right iliac fossa, hypogastric or suprapubic, and left iliac region. And these are the anatomy that is associated to the 9 regions. So on the right side, top right, we have the liver, we have the gallbladder, and a little bit of the right kidney. In the epigastrium, we have the stomach, liver, pancreas, also a bit of the right and left kidneys. Left hypochondriac region, we have our stomach, spleen, liver tip, and the top bit of the left kidney. Right and left lumbar regions, we have the right and left kidneys. Umbilical region, the stomach, pancreas, small bowel, and transverse colon. Right iliac region, small intestines, the appendix, which is very important. A lot of patients present with right iliac fossa pain, and the cecum and the ascending colon. We have the hypogastric region or suprapubic, small bowel, sigmoid colon, and also the bladder. And we have the left iliac region, which is the small intestines, descending colon, and the sigmoid colon. So the next few slides are quite busy. I'll just go through them really briefly. This came from the Royal College, which is basically everything that could relate to pain in these different regions. So very, very busy. Right hypochondrium, we have the gallbladder, the gastrointestinal tract, the GU tract. So then we could have anything to do with the gallbladder, gallstones, cholecystitis, empyema. We have the liver, so hepatomegaly, liver abscess, traumatic lacerations, GI tract, duodenal ulcer, with the urinary tract, where we have a bit of the kidney pyelonephritis. That's sort of the same for the left hypochondrium as well, except for the gallbladder and the liver. Epigastrium, we have the stomach, so a lot of patients with peptic or duodenal ulcers can present with epigastric pain that can radiate all the way to the back sometimes, especially with pancreatitis, that can happen. We have part of the gallbladder there as well, so some people with cholecystitis can have pain in the epigastric region and not just the right side. With the right and left hypochondrium, we have to remember that the bases of the lungs are also there. So some people with pleural effusions can have discomfort, even with pneumonia sometimes can cause pain or discomfort in that region as well. And then we have the flank or the loin, which where the kidney sits. So we have, if we can get pain with renal ureteric stone, with pyelonephritis. You can also get right and left flank pain with a leaking AAA with retroperitoneal tracking of blood. And that's basically the same again. In the umbilical region, early appendicitis. So if you catch appendicitis really early, patients tend to report central abdominal pain rather than right-sided lower abdo pain. We have the pancreas, and of course we have the aorta. So we always worry in older men of a AAA. Right iliac fossas, where appendicitis tend to present. Meckel's diverticulum is quite rare, so we won't really go into that. And into the groin, where you can get loin to groin pain with a renal or ureteric stone. And all of the gynae pathology as well, so ectopic pregnancies, ovarian cysts or torsions, and so on. And that's just the same again for the left, basically similar to the right. And then suprapubic pain, don't forget the bladder. So we tend to forget when someone presents with lower abdo pain that some people might just have simple urinary retention. Putting in a catheter could solve everything. Right, so I have a single best answer question. A 23-year-old woman presents with right iliac fossa pain of a 3-day duration. She is particularly tending the right iliac fossa when the left side is palpated. She's febrile, 38 degrees, and there is no history of any coryzal symptoms. I'm just going to start the poll. If people could vote. Okay, just give it a few more seconds. Okay, so most of you are correct. Appendicitis is the answer. And some people answered diverticulitis. So I'll just go through that briefly. I'll just go through all of the answers. So ovarian torsion, she's been having the pain for 3 days, so it makes it very unlikely that is a torsion because the pain is very, very acute, and they tend to present straight away, and also they don't tend to have a fever with it. Diverticulitis, it's quite uncommon in a 23-year-old. It's more common in the elderly, and a lot of patients with diverticulitis, they tend to have diverticular disease on the left side, so a lot of people will present with left-sided pain instead of right. And inguinal hernia, they don't travel, so it's not going to be, it's not going to change when you do the left iliac fossa palpation where the pain goes to the right. So the answer is appendicitis. So they do tend to present with fevers and a few day duration of pain. Because it's already been 3 days, the pain is more specific. So if she presented a day after the pain, she might be complaining of central pain instead of the right iliac fossa pain. Okay, so those were localized abdominal pain through the 9 regions. Just going to go through briefly what can cause diffused abdominal pain, so nowhere specific, just kind of all over the abdomen. Firstly, peritonitis. So that's peritoneal irritation of some sort of fluid. So it can be bowel content, it could be blood, so a perforation, so bowel content, it could be like a AAA, blood coming from vessels, and sometimes potentially the pain can be quite maximal over the underlying problem. Also, it's really important with peritonitis to take note of the preceding history. So if they told you about a week ago they had this pain in the epigastric region and then now it's just all over the abdomen, then you might think about a perforated peptic ulcer. And next is a bowel obstruction. So either small bowel or large bowel obstruction can present with diffused abdominal pain. With small bowel obstruction, it's usually quite central, and large bowel obstruction is in the peripheries, and they are both associated with abdominal distension. Bowel inflammation can be quite diffuse as well, especially in IBS or IBD. But in diverticulitis, as I've mentioned earlier, a lot of people get it in the left side of the colon. So quite a lot of people complain of left-sided pain. Appendicitis, which is early appendicitis, or perforated appendicitis, can present with diffuse abdominal pain. And a AAA can also present with diffuse abdominal pain. This depends whether it is a rupture or a leak. Some people present with very mild abdominal pain. So in older male patients, we have to be more cautious. I had a patient who was 93, I think, who presented with very vague UTI-like symptoms. He was maintaining his blood pressure really well, and then the next day we checked his bloods and his HB has dropped 40 units overnight without any clear signs of bleeding, and then we found out he had a leaking AAA. Right, we have another question. An 83-year-old woman with known AF presents with severe generalized abdominal pain, worse centrally. Examination findings did not really elicit any significant tenderness. However, she is profoundly acidotic on ABG. What is the most likely diagnosis? Okay, I'm going to give it a few more seconds. Okay. So the correct answer is C, mesenteric ischemia. I'll just go through that. Rupture AAA is a very fair answer, very fair differential. But note that she has severe generalized abdominal pain. Quite a lot of AAA patients don't have severe abdominal pain. Examination findings would usually elicit some symptoms of, the pulsatile mass in the center of the abdomen. Also, metabolic acidosis tends to happen with ischemia, where there's like a buildup of lactic acid. So don't tend to happen with a ruptured AAA. Also, she's a woman. It's a lot less common in women to have abdominal aortic aneurysms. Then B, small bowel obstruction. That's also quite a fair differential as well. So generalized abdominal pain, some people can have very severe generalized abdominal pain, where essentially key difference in this question is that she has known AF. That's what makes the difference. Diverticulitis, very good. No one answered diverticulitis because we've mentioned it's usually in the left lower quadrant. With AF, they can form emboli in the heart that can shoot out of the heart and block one of the vessels in the bowels. I can't remember which vessels are usually mainly affected, but that can happen, and the blockage will cause a reduced perfusion to the bowels and eventually causing mesenteric ischemia. Does that make sense? Hopefully. Okay, moving on. Yes, answer C. Examination. I'm sure everyone knows how to examine an abdomen, so it will be a very brief run through of them. Observations, end of the bed, palpation of all of the 9 regions of the abdomen, superficial palpation, deep palpation, and then palpating for the organs, percussion, especially for fluid levels, auscultation, bowel sounds. Bowel sounds are actually very, very difficult to differentiate. I'm not very good at it, and a lot of the times it doesn't tell us very much. Hernial orifices, just to cover every base, and also a digital rectal examination. Not a very pleasant test, and I don't know if anyone's heard, but a lot of surgeons believe there are only 2 contraindications to not doing a rectal examination, if anyone's heard. One is you not having a finger, and secondly, the patient not having an anus. So some surgeons are advocates for rectal examination, and they do it for everyone regardless of what they came in with. Some don't, but if there are any reasons to suspect any, especially lower kind of rectal problems, then a rectal examination is very, very important. And some older patients, especially patients with dementia, can present with quite bad abdominal pain with constipation, and then you do a rectal examination and you find just very hard lumpy stools in their rectum and give them a suppository and they're fine. Abdominal signs, not very common, but I think they show up in exams quite a lot. Murphy sign, if anyone knows what that is, can share them in the chat. Very good. So right upper quadrant pain, especially in deep inspiration when you palpate the right upper quadrant, can be a sign of acute cholecystitis. Charcot's sign or Charcot's triad. There we go, fever, jaundice, right upper quadrant pain. Crevier sign. Not sure how to pronounce that. So this is in painless jaundice, where you can palpate the gallbladder. In these cases, you would worry about a cholangiocarcinoma or cancer of the head of the pancreas. Gray Turner sign. Has anyone heard of that one? Those are very good. So bruises to the flanks with retroperitoneal dissection of blood. Quite severe, this can happen in severe acute pancreatitis. Cullen sign is also acute pancreatitis. And then the most common sign that you would see, I think probably I've only seen this one ever and none of the others, Rossing sign. I'm sure everyone knows what that is. Which is deep palpation in the left iliac fossa causing pain in right iliac fossa, which is acute appendicitis that we've discussed earlier. Right, so moving on, once you've taken a good history and you've examined and you sort of have some sort of idea what could be wrong in this patient, what blood tests would you request? Yep, FBC, CRP, all of the routines. LFTs are very important. Use and ease, yep. So these are the ones that are usually very important, especially in the surgical assessment unit. Quite a lot of hospitals have a surgical assessment unit blood test pack where you can just click on it and it has all of the tests that you should do in case you forget any of them. So FBCs, basically, as a junior, we don't really need to know very much. I know for exam purposes in medical school, they want you to know everything, but in real life, no one really expects you to know everything, and you're never left on your own. As an F1, especially, you always have an SHO with you or a reg. So FBC is always quite important, looking at inflammatory markers like the white cells, the hemoglobin, seeing if they've lost any blood, use and ease, any electrolyte derangement from whatever that they're experiencing. LFT is always very important in gallstones, gallstone problems. Group and save, always don't forget, because if they if there's a possibility of them going to theatre, then they would need a group and save. Blood culture might be relevant if they're spiking temperatures. CRP, always, if there's an inflammatory process somewhere, an infection, they would be raised. Blood gas, if you needed a point of care testing very quickly, then that would be very useful. Amylase or lipase, depending on which hospital you work in, different hospitals use different ones. I think I was told that lipase is a lot more specific than amylase, I'm not sure. Also tumor markers, if you think they are relevant. Does anyone remember any of the tumor markers that we would check, especially in patients that present with abdominal pain? Yep, CEA. So that's mainly for colorectal cancer. CA125, especially in elderly ladies. Ovarian cancer. There's CA99, so pancreatic cancer, AFP for hepatocellular carcinoma. So these don't always come back very quickly. They can help us kind of direct our diagnosis, but they don't tend to come back very quickly, as quick as FBCs and E's, which you can get back in half an hour or an hour. They're probably for further management. Right, next question. What metabolic abnormality is most commonly encountered in unwell patients with abdominal pain? Okay, I think most people have voted. Very good. Metabolic acidosis would be the most commonly encountered in unwell patients. So critically unwell patients with abdominal pain tend to have metabolic acidosis. So these unwell patients are usually the ones with mesenteric ischemia and so on. And the exact pathophysiology I cannot remember, but it's something to do with lactate buildup and tissue necrosis, tissue death that causes the acidosis. So it's D. We don't tend to do blood gases on patients coming onto the surgical assessment unit. A lot of hospitals don't tend to have an ABG machine on the surgical assessment unit. They're usually in ICU or the medical assessment unit. So it's not routinely done. Imaging would be the next step. This would heavily depend on which hospital you work in, where a lot of the time the junior is not allowed to actually request any imaging. Some places have clear-cut guidelines as to which imaging you can request. So usually they're the ones that are non-radiation imaging. So what sort of imaging modalities would we normally request for patients with abdominal pain? Yep, abdominal X-ray, very basic one. Ultrasound is very, very useful. So yeah, mainly X-ray, so plain films, chest and abdomen. So chest is always really important to make sure that they haven't perforated anything with the air under the diaphragm. Ultrasound, this could be specific, so ultrasound KUB, ultrasound abdo-pelvis. So in women, we tend to do a pelvic ultrasound as well. A CT, yep. MRI and endoscopy is technically not imaging, but there's a camera and it's also one of the main investigation modalities. So depending on where you work, there's usually a guideline saying which patients would warrant which imaging. Just go to the next bit. Yep. So with imaging, always have to remember the ease of access. So CTs take longer to happen. It will need a lot of vetting. It will need a senior to approve of the request and everything. So that can delay your diagnosis. Also have to remember patients' body habitus. So more obese patients, you can barely see anything on the ultrasound, so the ultrasound will not be useful in diagnosing someone with a with a higher BMI. We also have with body habitus with MRIs. If someone is larger than 150 kilograms, I think in my previous hospital was the cutoff, and they can't do MRIs because they won't be able to fit in the machine. Next will be radiation exposure. So you have to consider the age of the patient, the gender. So if it's a female or a male, female childbearing age, you're less likely to order a CT scan. You're more likely to go for an ultrasound. And also, how suitable is the modality for detecting what you're thinking of? Patients with renal stones, in my previous hospital, I used to work in Derriford in Plymouth. The cutoff was 40 years old. So anyone under the age of 40 would get an ultrasound KUB. Anyone over the age of 40 can get a CT KUB. With CTs, there's loads of different ones. So abdo-pelvis can be a CT angio if you're suspecting a ruptured AAA, or if you're suspecting mesenteric ischemia, wanting to see which vessels were affected. But yes, CTs take a long time. Not a lot of hospitals have many CT scanners. Some only have one or two. And the current hospital I work in now, if you are requesting the scan after 4 p.m., it can only be requested by a consultant. So that makes things more difficult if you're the only one there seeing the patients. So it's always important to remember ease of access, patient's body habitus, radiation exposure, and the suitability. Right, so another little question. A 30-year-old woman presented to the surgical assessment unit with right-sided abdominal pain radiating from the right flank to the groin. Which imaging modality is most suitable to further explore her symptoms or to even confirm your diagnosis? Just put up the poll. Okay, just a few more seconds. Right, I think most people have answered. Right, so if you've answered ultrasound KUB, then you are correct. Some have answered CT and some have answered abdominal X-ray. Okay. So I'll go through why they're not the chosen modality. So CT KUB is, as we've mentioned before, she's 30 years old, so she is a woman of childbearing age. So we don't tend to go for CT scans straight away. We tend to go with the non-radiating modality first. And usually in a young 30-year-old woman, an ultrasound is usually sufficient to see the stones. CT abdo-pelvis is also the same, so we don't tend to go for CT, and also the abdo-pelvis, you might not be able to see what we're looking for. An abdominal X-ray is quite useful because, especially if they have calcified stones, they will show up on the X-ray. But abdominal X-ray aren't as sensitive or as specific as an ultrasound KUB would be. Ultrasound KUB is normally the choice for possible renal colic. Basically, that's all I have. Very, very quick, very brief. Just something as a junior doctor need to know. So just some take-home messages. The location of abdominal pain is closely related to the underlying anatomical structure. So it's important to know the 9 regions and also the anatomy that is related to those 9 regions. They will help you formulate your differentials. Many conditions present with hallmark collection of symptoms that we can piece together to formulate the most likely diagnosis. So very typical ones would be appendicitis and renal colic. They're very, very textbooky. A thorough abdominal examination is essential to accurately formulate a list of differentials. So then 80% is from the history, and then the other 20% to complete it would be from the examination. And then a complete patient assessment will dictate the urgency of investigation. So if you think someone is really, really sick, based on their bloods or whatsoever, then these would dictate the urgency of maybe a CT scan. You know, a lot of radiologists will be a lot kinder in vetting your scans if they know how urgent it is. And if you've done a thorough patient assessment, you know what you're talking about. So when you talk to them to get them vetted, they tend to vet it straight away, even without the consultant talking on your behalf. And lastly, imaging requests should be prioritized according to patient's conditions and arranged urgently if surgery may be performed as a result. So as a junior doctor, you're the first protocol when patients come in. You are the one who sees them first. You would clerk them, you would make the initial management plan, and once everything is back, all of your investigations are back, that's when your seniors will come back and then review what you've done and if they agree or they need anything else done. That's it from me. If anyone has any questions, you can drop them in the chat. Yes, so KB stands for kidney, ureter, bladder. So it's focused on the kidney, the ureters, and the bladder. Any other questions? With her, so wouldn't have fever with hernia. No, so patients don't tend to present with a fever with hernia. What else is expected of a junior doctor? Actually, not very much. I think the knowledge expected of a medical student is a lot more than a junior doctor. When you become an F1, all you really need is a level head and organizational skills. So you do the very basic, you take a history, you do the examination, you request bloods. There's not a lot else that we're expected to do, but you are expected to escalate if you feel like it's beyond your knowledge. So if you think someone is really, really sick, needs to be seen right now by a senior, you can always bleep your reg or your consultant who is usually in theatres operating. You will never be expected to do very much. If patients deteriorate on the ward, we have an emergency medical team. They'll come and help. So it's basically just being really organized, knowing the very, very basics and knowing your limits of being a junior doctor.